of you are experiencing a peaceful and serene run-up to the hectic holiday season. I know how difficult it can be. Let's see, something is coming up here. Okay. So
just click on that to show your screen.
Okay. All right. Okay. We okay? All right. I know it can be hectic at this time of year, both personally and professionally, but maybe for the next several minutes or a couple of hours, we can take a break and think about the topic of selecting and implementing evidence-based practices, which is one that is certainly current for all of us as we seek to discover ways to serve the people that we serve even better than we do now. But first, here's a little word from our sponsor, I guess you could say, which is, let's see here, Chris.
Where you going, Jim?
Which is the ATTC network. As many of you know, the ATTC network is really a treasure trove of information about not only addictions treatment and prevention techniques, but also it has relevance for people across the behavioral health and even primary health care spectrum. And the goal of the ATTCs really are to do what we're doing today, raise awareness of evidence-based practices and promising treatment and recovery practices, to build skills, and to change practice by incorporating these new skills into everyday use at agencies around the country. Now, the ATTCs are spread around the country. You can see the map there and locate yours. We're coming to you today from the Northeast ATTC, which serves Pennsylvania and New York, but you can see there where you may be living and see the ATTC near you. The ATTC network, as I said, is a good place to go in order to get current information that will be useful to you in your various practices. And we can take a quick look, actually, at the ATTC website face page, and you'll see there all kinds of information available right on the website homepage, including finding your own regional center. But also, there are opportunities to learn more about different kinds of topics, and a feature on the Night of Blending products, which are very significant ways of maybe even looking at evidence-based practices that have been studied and put together by NIDA SAMHSA blending teams. And there's other good information right on the home page as well, as you can see there. And it's certainly worth perusing the ATTC network website. There's a lot of good information for you there. So we'll go back to the real world here. Okay, one of the things that the ATTC network is very concerned about, of course, is the whole process of technology transfer. And technology transfer is kind of an interesting concept. It relates to translational medicine in the physical medicine world, and it really encompasses the idea that research is being done on a regular basis about new, innovative, hopefully more effective techniques in order to provide prevention and treatment services across the board. But there's always a time lag involved, and some research has said that this time lag can be as much as 15 to 17 years before the development of more innovative practices and their translation into the real everyday world of medicine or behavioral health. And all of us, I think, can remember from our own personal experiences what this can look like as we move from old practices to newer ones. I remember myself when an uncle of mine had cataracts many years ago. This was back in the 1950s. And he went into the hospital for surgery, was there for 2 weeks. It was a very invasive operation involving tools that cut and scraped and other painful processes. And after that surgery was done, he had to stay in the hospital with his eyes covered, so he was effectively not seeing for most of those 2 weeks. And when he got out, he was given a pair of very thick glasses, which did enable him to see more clearly. But today, of course, cataract surgery is an outpatient procedure. You don't stay in the hospital at all. you get a new lens usually inserted into your eye, and pretty much off you go after maybe a couple of days of being careful and cautious. And so you can see what great progress was made on the physical medicine side just from looking at that. So somewhere along the way, new procedures, innovative practices were developed, and eventually over time transferred to the people in the field who could use those new developments and put them to practical use in their field of practice. And the same is true in behavioral health. Behavioral health, of course, as all of you folks know, is tricky. It's difficult to change behavior, but nevertheless, I think there are advances that have been made, and these advances have been studied and researched, and many of them are now ready to be transferred into the field, even as new research is going on. Now, just to get a little perspective on how this process works, well, this is a kind of a big perspective, I guess. We are here, meaning that physically we're kind of located in the far reaches of the Milky Way galaxy. So that's where we kind of are this afternoon as we participate in this webinar. It's kind of nice to fix ourselves in the universe, and a little bit humbling and intimidating at the same time. But a little closer to home, when we talk about technology transfer, we're actually kind of right here in the dissemination phase of technology transfer when we talk about selecting and implementing evidence-based practices. But this gives you the perspective of how new and innovative practices move from the development phase, where the research is being done and where new ideas are being tested and determined whether or not they're successful or worth adopting. And then moving into the translation phase, and this is a phase where there's an attempt to explain the essential elements and even the relevance of an innovation, and then to begin to package it for the next phase, which is the dissemination phase, which is where we are today, where we're promoting an awareness of various innovations with the goal of hopefully moving them toward adoption and even implementation. And then there is the adoption phase itself, which is really just the process of deciding whether or not to use an innovation. This may or may not lead to the next phase, which is implementation. But implementation, in its best sense, means incorporating the new approach, new technique, new idea into routine practice. So it now becomes the standard. It's no longer an outlying type thing, but it's now part of the daily activity of an agency or of a practitioner. Notice that the arrows go then back toward the development phase, so that there is a kind of bidirectionality to this process, which means that as new practices are implemented in the field, it's important to get feedback back to the developers and to folks that are in the research end of things, so that these new innovative techniques can be tested and tweaked and developed further if necessary. So that dialogue is very important as this process moves along. Now, today we're going to look specifically at evidence-based practices, and I want to reiterate what Chris said earlier, that if you have questions, if you have stories about your own experiences implementing or attempting to implement evidence-based practices, if you have comments or other thoughts, please feel free to send those our way, and we'll want to hear about those and respond to those or listen to the wisdom that's out there in the group this afternoon. But some of the things we're going to look toward achieving today, we're going to hopefully outline a comprehensive strategy for selecting and implementing a practice. This can be a bit of a daunting task, but we'll take a stab at least introducing ourselves to this. Then we'll have a discussion of barriers and challenges, because they are certainly out there and are very relevant when we begin to think about how we're going to do this. We're going to review the need for organizational self-assessment to determine readiness for change, and this is very important before you even begin to think about implementing an evidence-based practice, really understanding how your organization is structured in order to be ready for the kinds of changes that will be necessary to successfully implement a new practice. We're going to examine a framework for evaluating evidence-based practices because they're not all created equal. Some of them are good in general, but maybe not good specifically for your particular situation. And so it's important to understand that. We don't want to become so enamored of a particular evidence-based practice that we try to force it into a setting where it isn't going to work for whatever reason. We can talk about that a little bit. Another thing that we kind of discussed already is describing a model for technology transfer. We kind of looked at that model from the ATTC world, which I think is a good model to keep in mind as we think about how technology transfer works. We want to describe the necessary steps for successful implementation of an evidence-based practice, and hopefully also discuss steps necessary to ensure fidelity. So let's start, Chris, with our first poll, basically to kind of see who's out there today and to get a sense of who our audience is as we begin the webinar this afternoon. So, Chris, do you want to run that poll?
Yes, I just put it out there, and we would like people to please just click on the what you consider as your professional role, whether it's counselor, therapist, social worker, case manager, or in the healthcare form. Let's see, is a nurse, nurse practitioner, physician, physician assistant, either a program or unit administrator. Are you in local, state, or federal government? And if you are considered other, please go to the questions box and enter your profession in that, because we'd like to capture the full range that we have here in our participants. Okay, I'm up to 68% now. We'll wait another couple seconds or so. Okay, we have somebody that is in the other, and that's a trainer. So there's a parole agent. So these are people that we only had 5 options, so we would have added more if we could have. Okay, it looks like we're up to about 81% now. So I'll just read these off to you, Jim. I'm going to close the poll, and then we'll share the results. Jim, we have 31% saying that they're counselors or therapists, social worker, case manager. 4% are in the healthcare profession as a nurse or physician or assistant. 12% program or unit administrators. 42% are in local, state, or federal government. And 12% are other. And like I said, I've gotten information about a trainer or a faculty trainer, and then also the parole agent. So that is the result of that poll. You want me to go over any of that again for you, Jim?
No, that's fine, Chris. Thanks very much. That gives us an idea of the diversity of our audience here today, and it's good to have all of you with us with your different perspectives, and this can help us maybe to have some discussion as we go forward. I know the webinar format is sometimes unwieldy at times, but we'll do our best to hear from folks and to process comments and questions and, as I say, thoughts, stories about experiences, those kinds of things. So thanks for being with us today. All right, now why am I stuck here, Chris? Okay. All right, let's go back then to a definition of evidence-based practices. And here's a good one from Blaze and Fixon. A program or practice that has been demonstrated through scientific studies to be effective in improving outcomes for a specific population. And this sounds like a good researcher's definition, and then we should certainly start there. So we're interested in the fact that we're talking here about scientific studies, bringing science to bear, and also improving outcomes, which is really the goal of evidence-based practices and hopefully the goal of all of us as we go through our day. All right, now there are a couple of reactions that can be typical as we think about change in general and evidence-based practices in particular. Some portion of our population may feel that this whole discussion of evidence-based practices is nothing but hogwash, just another thing coming down the pike. It'll pass too, like everything else, and so it's just plain old hogwash. Some people take the approach that we did it this way last year, so it should be good enough now. There's no real need for change. Things kind of work pretty well the way they are. Another reaction, though, might be that we're in the kind of contemplation phase of thinking about evidence-based practices. That, okay, there might be something here. There might be something we should listen to and maybe incorporate. And then, of course, there are the enthusiastic adopters and embracers of evidence-based practices. Now, we might want to get through our next poll an idea of where all of you are in terms of some of those things, not exactly those categories. So, Chris, if you take a second and run the next poll, that would be helpful.
Okay, that's up. People, please click on where you think you stand as far as your thoughts on evidence-based practices.
And specifically concerning change and the ability to make changes.
Okay, we'll give this another few seconds here to get more people involved. Okay, we're up to 65%. We'll wait another couple seconds. Okay, I think I will close the poll at this time and share the results. Let's see. We have 8% say that they are skeptical about the value of evidence-based practices. 12% are satisfied with the current practices they have. 24% would like more information. And 12% are interested in adopting it. And you have 44% who are already implementing. And we have one abstention here who says he provides trainings on evidence-based practices to those who are considered making the change or are resistant to do so. So, Chris, I hope we hear more from you and some of the challenges you face. Okay, I'm going to hide this then, Jim, and it's back to you.
Okay, thanks very much, Chris. And it's interesting that we have 44% of you that are already implementing an evidence-based practice. So, again, we may hear from you and hear what some of your experiences have been like, and then some of this information then will be kind of a review for you folks. We do have some skeptical folks in the audience, and that's always good. A little healthy skepticism about anything is a good thing. So it's good to see what the spread is there. I know some of these are forced choices and don't give you the opportunity maybe to say exactly where you are on these issues, but I think it gives us an idea of where folks are as we move along here. So why should you care about evidence-based practices? Well, basically, I think it's important for all of us in the behavioral health services field, whether it's in prevention or treatment or primary care or whatever, to be interested in what's happening currently in research that could affect our practice on a daily basis. We want to know what works. You know, if the folks in cataract surgery had said, hey, it's good enough to throw somebody in the hospital for 2 weeks, scrape away at their eyeballs, send them home with a big, thick pair of glasses, that's good enough for us. We may not have made advances which makes that surgery much more comfortable for people and much more effective. So we want to know what works, and we also know that even what works today might be replaced later by more effective treatments. And the fact of the matter is that payers and funders, including states and others, are increasingly concerned with outcomes. And so they want to know what they're paying for. I know I had a long career in the addiction treatment world, and I've certainly had my tussles with managed care companies along the way in terms of treatment plans and things like that. But it is true to say that people that are paying for something have a right to know what it is they're paying for and whether or not it's producing outcomes that are positive. And so we see that some payers and funders are requesting the use of evidence-based practices, and some people are even demanding that evidence-based practices be adopted. I know some states are beginning to move in that direction. And most importantly, of course, is because these are tools that can be effective in helping our clients to get better. Just last night, I was at an emergency room at a hospital that we're working with. This emergency department is adopting the screening, brief intervention, and referral to treatment protocol. And in speaking one-on-one with one of the nurses there about his experience using this protocol, and also the difference in an emergency room setting where the culture is, let's get this person physically stabilized, let's sew them up or dress the wound or do what we need to do, that sometimes attending to behavioral health concerns can be difficult. But I thought he gave a very appropriate and insightful response when we talked about not only attending to a person's physical needs, but having in place a tool, a screening tool, which can be effective in helping people look at and possibly adjust the way they use alcohol and drugs. And he said that one of the reasons he got into nursing was to help people improve their lives. And so he wasn't just narrowly focused on sewing them up and dressing their wounds, but on the broader issue of helping folks to improve their lives. And so the tools that we can discover through an exploration of evidence-based practices and maybe that we can adopt are effective in that sense, that they can help people improve their lives, and that's really what we're about. And so why shouldn't we be interested in applying science to what we do and improving the way we approach our patients? Now, nevertheless, just because a practice or an innovation has an evidence base doesn't necessarily mean that it's right for your region or your agency. So what we have to consider here is what's it like in your neck of the woods, what kind of situations are you dealing with, and what evidence-based practice specific one might be appropriate for your region or your agency, because one size definitely does not fit all. Now, we begin with Alice here. One day Alice came to a fork in the road and saw a Cheshire cat in a tree. Which road to take, she asked. His response was a question. Where do you want to go? I don't know, Alice answered. Then, said the cat, it doesn't matter. And we want to try to avoid that situation. We want to develop a sense of where we need to go before we begin the process of implementing an evidence-based practice. So it can't be stressed too much that this kind of work, developing a sense of where we want to go, really we need to pay attention to this up front and early on, because it's going to begin to kick off a process of change that will certainly not be effective if we don't have a very clear sense of why we're going down this road to begin with. So developing that sense of what our goals are, why we're doing this, why we think this practice might be effective, and most importantly, what kind of steps are we going to need to take even before we consider what evidence-based practice we're going to adopt. What kind of steps do we need to take in order to build an effective change process in our particular agency or in our practice, however that works out? So we want to think for a minute about the process of change, and we have one other little poll here, poll number 3, I believe, Chris. So if we could run that out and see where people are on this subject of change, it'll be helpful as we move forward to discuss building an effective change process.
Okay, that poll is up and ready for responses. Okay, we're up to 62% already, so I'll just wait a little bit longer. Okay, we're up to 85%. I think that that's a good number. So I'm going to close the poll at this time. And the results, Jim, are that 69% of the people feel that their organization embraces change. 28% feel that their organization is reluctant to make changes. And 3% are just too busy to think about making changes.
Okay, thanks very much, Chris. Yeah, and being too busy to think about making changes is certainly something we can all relate to. Again, when I was in this very busy emergency room last night, thinking about how they're going to adopt the ESPERT protocol, it certainly was, you know, a touching base with reality to see how busy that environment was and what it was going to take in terms of commitment and even sacrifice on the part of the nurses to make that kind of change in that kind of environment. Sounds like most people are ready to embrace change or work for agencies that are ready to embrace change, and that's very, very good. But we shouldn't underestimate that making changes in our own lives is difficult. Think of the various New Year's Eve resolutions that you've made over the years. We have another New Year's coming up here shortly, and how successful or lack of success you experience in making those particular changes. And I can even think of a kind of a quirky example from my own life. A number of years ago, I had an accident, a kind of skiing accident, where I shattered my elbow. And so I lost the use of my right hand for a couple of weeks, about 6. It was kind of gradually coming back over the course of about 6 weeks. But when I went back to work in the early days of my recovery, I didn't have use of my right hand very much at all. And so I had to use my left hand for everything. Well, when I would sit down to the computer for the first couple of days, I kept reaching across my body and taking my mouse and using my mouse, which was located, of course, on the right side of my computer screen because I was right-handed. And it took me those couple of days to figure out that left-handed people whose ranks I had at least temporarily joined probably kept their mouse on the left side of their computer screen. And so when I came to that brilliant conclusion, I moved it over there, and things went a little more smoothly. But that just is an example of how our brains get kind of hardwired to do things in a certain way. So making changes is not necessarily easy. It's certainly not easy on a personal level, and it can be difficult on an organizational level because you're bringing in the factor of many people having to be engaged in the process of making a change. But if we look for a minute at guidelines for building an effective change process, we see these kinds of guidelines that hopefully can be helpful for us. The first thing we need to do, as we talked about earlier, base our objectives on the client or agency need, know where we're going, and support this with data when possible. It's very important, I think, to understand why a need has arisen. I remember being involved in a process of trying to determine why a no-show rate or a dropout rate was high in one of our outpatient facilities. And so we undertook a data study to look at what was happening, what could we learn from the data. And what we learned was that most people dropped out of treatment in the first 3 sessions. After that, if people kind of survived those first 3 sessions, they usually hung in with the treatment process pretty much till the end. So having that data in hand meant that we didn't have to kind of wonder about what was going on or take a guess, an educated guess. We may have come up with the right answer through that method, but the data clearly showed that we needed to put more effort into engaging our patients in treatment from the very beginning and actually give them more attention early on in treatment until they attach to the treatment process. So basing your objectives then on the agency need that's supported by data is a very important place to begin when you're thinking about making a change or adopting an evidence-based practice. Secondly, we need to select objectives that management will fully support. Now, this is important because if management doesn't support these changes, they likely are not going to happen. And so management has to be part of the process from the beginning, at least to get their input and to get their cooperation and hopefully enthusiastic support as the change process moves along. The third is we need to assess for a match with the agency mission and values. And this may seem obvious at first, but it certainly is worth thinking about. If your agency is a mission-driven agency, then when you adopt any new practices, you want to make sure they're matching up with that mission and not taking you off in some direction that's completely different. If your agency is experiencing some financial difficulties in your behavioral health clinic, you're not going to start selling Christmas cards in order to help support the agency. That doesn't really have much to do with your mission. You're going to look for a match, something that works in conjunction with your mission and values in order to proceed with a change that's going to make an impact. The fourth thing is, obviously, we want to make objectives specific, achievable, and measurable. That sounds like a treatment plan, which is not that much different from. And the fifth is we want to appoint a change leader. Now, a change leader doesn't have to be the head of an agency or the clinical supervisor. In fact, some of those folks might be too busy to be the one who kind of shepherds the change process along. A change leader should be somebody who, number one, is enthusiastic about the change. Number two, understands the purposes and goals of the change. And if a specific evidence-based practice is selected, somebody who really understands how that practice is supposed to work. So these are the first 5 guidelines that constitute the foundations of developing an effective change process. And like the foundations for a house, these guidelines form the basis for moving ahead with any change initiative. Now, stopping there briefly, Chris, are there any questions or comments that we should address at this point?
No, I don't have any. Thanks, Jim.
Okay, well then we will press ahead. The next set of change, effective change process guidelines, which we call the framework. Number 6, then, you have your change leader. The change leader just can't be out there on their own. They have to work with a team to plan the improvement. So that if we have now a change leader, we can assemble a change team, a group of people that should be broadly representative of what happens in the agency. Everybody from frontline people at the receptionist desks, through counselors, through supervisors if possible, other people that you might not think of or might be specific to your agency. So we want to get this team together because as we look at moving forward, all perspectives can be useful in developing a plan to move forward successfully. Now we want to be sure to include opinion leaders on the change team. Now opinion leaders are people not the same as the change leader. Opinion leaders are people in your environment who, for whatever reason, maybe they've been there a long time or they're just respected by the other staff members. These are people that are seen as leaders even though they may not hold a leadership position because they speak up at staff meetings or they have opinions, sometimes opinions to the contrary. But these are folks who are opinion leaders. And it's important to bring them into the process, whether or not they are positive or even if they are negative. It's important to bring them in. If they're positive, of course, it can be a little bit easier. But if they're negative, it might be important to have the change leader or someone else invite them to be part of the process, engage them on an individual basis, and see if at least they're willing to participate in the process, which can lead to an improvement for everybody. An example, an interesting example of bringing an opinion leader, although this wasn't exactly an opinion leader, but bringing an opinion leader into a process is that many years ago, I actually worked for a church in Atlanta, Georgia, and the church ran a buyer's club, which at the time was like a co-op, buying large bulk items, bulk food items, et cetera, other kinds of items, storing them in a warehouse, and people who belonged to the buyer's club then could have access to those things on a reduced price basis. And the woman who led the buyer's club, or who was the director of the buyer's club, was a very sharp person who understood the community well and had relationships in the community. And after a while, the buyer's club was experiencing some problems with break-ins. People were breaking into the warehouse, and petty theft was occurring. Now, because the woman who ran this operation was so well connected with the community, she quickly understood who was causing this to happen, who were the ringleaders of these break-ins. Now, she had a number of choices that she could have pursued. She could have called the police. She could have instituted maybe a stakeout to see if they could be caught red-handed. This was before the days of video surveillance cameras, or if they were available, they would have been way too expensive for us. But what she did instead was she sought out the people that she knew or felt were quite likely to be at the root of this, and she invited them to join the board of directors of the Buyers Club. And so now they had a stake in the success of the Buyers Club, and the petty theft stopped. So she took these negative forces and brought them into the process in order to make the process go more smoothly. And they certainly had a lot of opinions about how the warehouse could be made more secure, and how we could stop these petty thefts from occurring. And the same isn't that it's not that much different when you bring even a negative opinion leader into the change process. Is that they may have perspectives that are certainly worth hearing, and they can sometimes then become an advocate and an influential advocate for change, even though initially they started out from a negative base. If they're, of course, completely negative and undermining, they may not be a good one to have on the change team. But many opinion leaders who initially appear to be negative can be brought along and make a positive contribution. The next thing is very important. Develop a detailed plan and start small. The process of implementing evidence-based practices will take time and effort stretched out over months and even in some cases over years. This should not be daunting or discouraging. It's better to develop a detailed plan. You can put this plan on a spreadsheet. It can become a task list or whatever system works best for you. Each task being assigned someone who's responsible, maybe a timeline. But the process should be detailed, orderly, and the steps should be small enough so that you can take them one at a time on the way toward a big change. Number 8 is to thoroughly prepare supervisors and staff for the changes that are being proposed. So that people need to know. The process needs to be transparent. It doesn't happen in some room somewhere with doors closed, and then, ta-ta, we come out and announce this thing. It has to be transparent from the beginning, and people need to be prepared along the way so that it's not a surprise. The end product is not a surprise for anybody. Then the 9th thing is that we need to monitor fidelity, usually via direct observation, so that we know that the practice is being implemented in a way that's consistent with what the research is showing. Whoops, where were we? Okay. Now these 4 steps are the framework for change, and like the walls and roof of a house, they comprise what most people see when viewing a change. Now, too often the change process is perceived to end here, but we know we're not really done. There's more finishing work that has to happen. And the finishing work are these steps. We need to track the change through monitoring data. So as you implement the practice, you want to have points where you're tracking what's going on here. Is the evidence-based practice implementation occurring as it should? Is it occurring at all? Are people actually using the practice? Is it having the type of effect on the patients that we want it to have? Are they responding properly to the evidence-based practice? Are we seeing results in terms of our original goals actually happening. This is very important, going back to the way we set up our plan, which included our goals and objectives. So we want to monitor that progress, and we want to collect data along the way. We also, number 11, we want to make adjustments as needed based on staff and client feedback. Someone came up with this kind of quick and pithy formula. When you adopt a change or an evidence-based practice, or you're taking the steps toward doing that, you want to assess and determine whether you're going to keep it, tweak it, or dump it. And I think that's a good way to look at it. We want to make sure that we're getting the feedback. If we have to tweak the practice or make some changes to make it more effective, to make the process more effective, then we want to be able to do that in real time with feedback. Number 12 is, again, goes back to transparency. We want to keep all staff informed about progress. How's it going? We don't want to sugarcoat anything. We want to be out there with the real truth. Number 13, when objectives are achieved, we want to celebrate and spread what works. We want to give acknowledgement. Hey, this change is having an impact, and we want to make sure that we're spreading it around. And the 14th is we want to develop a sustainability plan to assure the maintenance of improvement. And we want to actually think about sustainability from the very, very beginning. As we select an evidence-based practice, we want to really be thinking about sustainability. We'll be talking more about fidelity and sustainability issues later. But we want to begin to think about those very early in the process. We don't want to adopt a plan where we may be getting the hint that this is not going to be sustainable over the long haul. So those are the guidelines for building an effective change process, and I think it's we can see that if we follow those, we have this really nice house, and the modifications and improvements have been made, and you can see the happy couple ready to move in there. So we're ready to begin the process of adopting an evidence-based practice. Okay, we'll move ahead, Chris, if there's no comments or questions, which I assume there's not, or you would have interrupted me.
I wouldn't have interrupted you.
Okay.
No comments.
Or you would have alerted me, I should have said.
Yes. No questions.
Okay.
Thanks.
All right. Okay, and again, any of you that have been through this process and have comments, we'd love to hear your stories and your comments and your real-life experiences. Okay, certainly barriers or challenges can emerge as we begin to implement a change process that's going to lead us to the development and the adoption, lead us to the adoption and implementation of an evidence-based practice. And some of the barriers include administrative philosophy and organizational policy. These are the kinds of things that might need to be examined as we move forward so that the policy structure supports the change that you're proposing. The system structure itself, are we structured properly as an organization so that if we adopt this change that we're going to be able to sustain it and implement it properly. There may be some resistance from agency staff. We talked about the transparency, the necessity of transparency in this process so people have a chance to understand what's going on and to raise their objections as we're going along. There might be insufficient communication. Often busy agencies will lack sufficient communication up and down the line, and I think it's important to take a look at that so that people are aware of what's going on. Something that maybe isn't on this list is timing. Sometimes the timing of the introduction of an evidence-based practice is important. You don't want there to be a memo going out that says on Monday we're going to be adopting our new computer software, and the HR department wants you to drop by to their seminar because we're adopting a new paid time off policy, and by the way, we're also adopting an evidence-based practice, and blah, blah, blah. Well, no, agencies need to have time to adjust to any of those kinds of changes, much less dumping them all on an agency at one time. So we want to make sure the timing is correct. Obviously, the board of directors can be a barrier at times, a surprising one. I know in the organization that I worked for, we were had a lot of staff buy-in to making a specific change in practice. And when it went before the board of directors in kind of a routine way, one of the board members raised a vigorous objection to moving in that direction. He thought it was not in line with our mission. And as a result, the process really had to be slowed down dramatically. So you can have a barrier even from the board of directors. So the board should be brought along as well in the process. I think our mistake there was going to the board too late in the process, as though we were ready to do this without consulting, not necessarily consulting, but informing and getting their input earlier. Consulting, I guess you could say, the board of directors. Also, a barrier can be your client population, and that's why you have to be careful to select an evidence-based practice that's appropriate for that the population that you're dealing with and targeting. Other barriers can include the innovation itself may be difficult to implement. There may be limited organizational resources. Some evidence-based practices may require medications or technology or even physical space that a particular organization or agency just doesn't have. Financing issues can be another obstacle. Evidence-based practices can typically cost something. There are some that are free, but many of them are proprietary, and there are startup costs related to implementing them. And so this can become a barrier to adoption. Obviously, in terms of finances, and sometimes this can be a hard or easy case to make, I think all good evidence-based practices that are implemented properly and work well help to increase client retention, and with increased client retention can come increased revenue for an agency. So even though there may be some upfront costs, if the evidence-based practice works well and patients or clients stay in treatment longer, that can have a positive effect on the bottom line for an agency. But nevertheless, there may be costs that are prohibitive. Now, there are evidence-based practices out there, but is your region or agency ready to begin the process of implementing an evidence-based practice? Well, there's questions to consider. The task of assessing the readiness of your region is part of the preparation stage for evidence-based practices. So you want to take the time to assess your readiness. And you can ask yourself, what is your organization's level of readiness? Now, some of you, 69% of you, said that you work for an organization that willingly and enthusiastically embraced change, and that's a wonderful thing. But in terms of when the boots hit the ground, what is your organization's level of readiness? There may be a philosophical embracing of the concept of change, but are you actually ready? And what aspects of your organization point to readiness? Can you be specific about that? Well, we do have these resources, and we have this space. We have financial resources in place. So it's not just, yeah, rah, rah, we love to have change at this organization, but we actually have the means. And what aspects of your organization would require additional support or additional resources? A very important thing to consider. So all of this, this process of change and preparing for change and assessing your readiness for change, all of this really needs to be done before you go to the well and determine whether you want to select an evidence-based practice for implementation. You want to prepare the groundwork, so to speak. You want to have the framework in place, and then the evidence-based practice selection process can begin, and you'll know that you're ready to take that step. Okay, how can we conceptualize and rank evidence-based practices? Well, there are ways of thinking about rankings or what's the best, the next best, the top rank. And basically they can be categorized like this. There's kind of a third tier, a second tier, and a gold standard. And the third tier is practices that are based on expert opinions about clinical observations. So you can read an article, you can talk to colleagues, experienced colleagues, and you can get a sense that here's something that may be worth trying, that may help us out, that may increased client outcomes. But it's an expert opinion-based type of evidence-based practice. There's a second tier, which is a consensus review, where it's not just this or that expert, but it can be a consensus of experts. Sometimes this can be characterized as a consensus review based on a Delphi method. A Delphi method is kind of a structured communication technique. It relies on panels of experts or a panel of experts, and then there's a process whereby the experts answer questionnaires in a couple of rounds, and there's a revising of the answers in light of how people respond to the questionnaires, and the replies keep getting more focused until there's a convergence that if we do it this way, this is the consensus that this would be a good way to do it. We're involved in a process now around best practices for the use of buprenorphine in substance abuse treatment. And we're doing that kind of an approach where we're essentially polling or questioning people in the field who are using buprenorphine in their practices. These would be physicians using it in private practice, so that we can come to a consensus of what would be the best practices with regard to prescribing and monitoring a patient's use of buprenorphine in an outpatient setting for a primary care physician, and what other kinds of things need to be in place, like counseling and things like that. But that's a consensus review. And then the gold standard, of course, is multiple randomized clinical trials that what we usually think of when we think of high-level research. Okay, now there are two specific frameworks for evaluating a practice or innovation. One is the National Registry of Evidence-Based Programs and Practices. This is a SAMHSA website, which is a compilation of evidence-based programs and practices. It's useful for assessing whether or not an intervention is an evidence-based practice, and we're going to take a look at that in a minute. But it's a good place to go if we want to see where evidence-based practices, at least some of them, not all, but some of them live. If you're thinking about an evidence-based practice, it can be a good place to start to get information that will be helpful in determining whether that's the evidence-based practice for you. And then another useful tool is the Iowa Practice Improvement Collaborative PIC criteria. And this is useful for assessing whether or not an intervention is the right one for your region or agency. So up above on the NREPP website, you can see a vast array of evidence-based practices, and by using the PIC criteria, you can determine whether a specific practice is the one for you, is the right one for your agency or your region. Okay, Chris, we have another poll at this point to determine people's familiarity here with the NREPP site. Could you run that poll? Chris, I'm not hearing the results.
Sorry. 71% are not familiar with it. 29% are familiar with the site. Jim, did you hear it?
No, could you repeat that, Chris?
Okay, sure. 29% are familiar with the site, and 71% are not.
Okay. Thanks, Chris.
Sure.
Okay, so some of you are familiar, but most of you are not, and so we'll have a chance to look at that site in a minute. So the National Registry of Evidence-Based Programs and Practices, this is a searchable online registry of mental health and substance abuse intervention. So it's not just focused on substance abuse, because this is a SAMHSA website. These have been reviewed and rated by independent reviewers, which we'll see. And this is available to the public, and it's there to assist us in identifying approaches to preventing and treating mental and/or substance use disorders that have been scientifically tested and that can be readily disseminated to the field. So NREPP can be then a first step in promoting informed decision making, but it's not the last step. It can't. It doesn't necessarily help you to. Well, it will help you to determine, whether the intervention meets your particular needs, but you have to do some work with it in order for that to happen. Obviously, it doesn't know your situation, so it can't tell you. Okay, so here's what NREPP does. It provides descriptive information. It evaluates the supporting science in terms of the quality of research. It provides an indicator or measure of the intervention's readiness for dissemination and thus readiness for adoption. And so you can see there the descriptive information includes those kinds of things. Notice that demonstrated outcomes are there, population descriptors are there, adaptations, costs, which will be important. It's all there. And it also gives you information about the quality of research measures. We'll see that when we go to the site. And then it talks about readiness for dissemination, so that you know how available are the implementation materials, availability of training and support resources, availability of quality assurance procedures. All of these things are there for you. So now we're going to take a look at the website. And for those of you that aren't familiar, this might be your first look. And for those of you that have seen this before, bear with us. It'll be a review for you. And we'll get it up here. Okay. So this is the NREPP homepage here. It looks rather unassuming. And there's a couple of ways you can maneuver through this site. You can look at all the interventions if you want. They're all lined up there. And these interventions, if you out there, some of you may have actually, you may be on this website. You may have developed an intervention and submitted it to NREPP for inclusion on this website. That's basically the process. People develop certain promising programs and practices, and they'll send those off to NREPP for review, and they may be accepted or rejected for posting on the NREPP site. So you can see there's 219 interventions. So you can just go down the line there, and if one jumps out at you, you can certainly click on it, and you'll see what you need to see. The advanced search allows you to, put in something specific to your particular program. So we'll try an advanced search. Suppose we're interested in substance abuse prevention, and suppose we want to say that the age group is going to be maybe two age groups. We're going to do 18 to 25 and 26 to 55, and suppose we're interested in alcohol, just for the fun of it. And suppose we want to say that we're not going to specify. We want it to be a broad race or ethnicity, as will be unspecified. Suppose we're in an urban and suburban setting. And suppose we're looking for something which is just out there in the community, other community settings. And so we hit the search button and we see what comes up. And we can see that there's a number of things that come up here. And so then we maybe want to click on one. And here's one that some of you might be familiar with. I know we have a lot of state government or local government people with us, and this is one that's often used with DUI offenders, Prime for Life. And so we pull up Prime for Life. The first thing we see is the description of what this is. We're not going to belabor this too much, but if you were interested in this, obviously, you'd take a few minutes and you'd read through that and you'd say, okay, this looks interesting, or it doesn't look interesting. If it doesn't look interesting, you go out and you would select maybe another practice or put in different parameters or whatever. And here's the descriptive information here, which talks about what outcomes they're looking for. These are areas that this practice is designed to impact. These areas: perceived risk for alcoholism or addiction, intention to drink or use drugs, self-assessment of alcohol or drug-related problems, recidivism. We want to impact those areas, and you can look at the various other things that are there. You can look for adaptations. In this particular one, the instructor materials and participant workbooks have been adapted for use with adolescents. That could be useful information for you. And as well as with Cypriot and Swedish cultures, which may not be as useful for you, but it could be. Thus, materials have been translated into Greek, Spanish, which might be significant, Spanish and Swedish. Maybe not quite as significant unless you're with us from Minnesota, perhaps, or that region of the country. That gives you the Institute of Medicine Prevention categories. Some of you may be familiar with what those are. Some of you may not be, but those have to do, and all of the practices will have that. Universal means that this practice really is good. It could be used in the general population. Selective means this practice could be used for a population that is considered at risk. And indicated basically means that these are folks who are already experiencing the early danger signs related to what this particular practice is trying to impact. In this case, Prime for Life is appropriate for all of those categories. Many of the others would just be for one or other of those categories. Down here we have other things you can look at. We don't want to look at all of these in the interest of time. But we can look at, for instance, you might be interested in quality of research. And so here's a whole section on that. You can see the scores there. You can see that all of these get overall ratings in all of these areas, the areas that they wanted to impact as they studied the effect of this practice on these areas that they wanted to impact. You can see what the ratings there were for reliability, validity, Fidelity, those kinds of things, and then the overall rating there in the far corner. And then it tells you about the study strengths and the study weaknesses. And you can look at that and determine whether that might influence your decision. You might want to look at readiness for dissemination. How if you want to use this practice, are there materials out there that are going to help you? And you can begin to see down here that there are, it gets a pretty high score in terms of implementation materials. Training and support resources gets the highest score. Quality assurance procedures gets the highest score. Implementation gets the highest score as well, and you can see that there. But it also then lists the dissemination strengths and dissemination weaknesses. Again, you know, we won't belabor that, but you can read those on any of the evidence-based practices listed here and see whether those would influence your decision to select this evidence-based practice or not. Now we get to the area of cost, because this is a factor for you. You may love this. You may love this particular evidence-based practice all the way down to here, and then you click on cost, and you can see that it isn't completely cost-free. That there are participant workbooks that cost a pretty broad range. They're $7.50 to $30 each. So we need to investigate that a little bit and see why there's such a broad range. Is there like a basic workbook that we could get by with and a more enhanced workbook, or what does that really mean? But there is a cost. We know there's a cost there, and we also know, if we look over here in the last column, that this particular item, the workbook, is required by the program developer. So that's not a negotiable. We have to have those workbooks. We also see that some training is needed. We don't know how much that's going to cost because it varies depending on location of training. So we need to do some more exploring there. Looks like it's pretty extensive. It's 4-day off-site training. That's a big time commitment for staff that might need to be sent, or a staff person that needs to be sent. So we need to determine whether we can handle that, or the training can be provided on site, and so that's another option. Again, this is not specific. I'm not trying to. This isn't about the PRIDE program. Is just an example of an evidence-based practice, and you would see this kind of information no matter which one you are perusing. So those are some things to look at. There may be some other things you would be interested in. You might be interested in looking at the outcome data, the study populations, the quality of research. It's all there. Now let's go up here. This is very important because we talked about you might need more information about costs or the workbooks or the training. Where are you going to get that information? Well, learn more. For information on implementation, you contact these folks who are involved with the development or are involved currently with the development of Prime for Life. Okay, so these are your contact people, and you cannot be shy about contacting them with your questions. And if you wonder what kind of questions you should ask, you can click on here for some suggestions. These are questions to ask as you explore the possible use of an intervention. There's questions about implementation. You know, you want to know where this intervention has been implemented, in what settings, with what populations, because this can help you to determine whether it's going to be useful for your setting and population. You want to know what some of the particular challenges are involved here. What are other people experiencing? What common mistakes have been made? How might you avoid them? Can you provide contact information? This is very important for 2 or 3 directors of implementation sites that are currently in the process of implementing the intervention, so that you can talk to colleagues who may already be using this intervention. What's their experience with it? You may be interested in adaptations, and you might want to look at whether the intervention has been adapted in any ways that might be relevant to its implementation in a setting like yours. You can describe the setting, or with a population like yours. You can describe the population. Are there any core components that can't be tampered with? You'll want to know that. You want to know information maybe about staffing, the staffing requirements. Are there minimum staff qualifications? What methods are used to select the best candidate? All of this information you may get from the developers or the keepers of this particular evidence-based practice, no matter which one it is. You might want to know the quality assurance mechanisms that are available. The core components that define the essence of the intervention, how supervisors are prepared to provide effective support, questions like that. You may want to have questions about training and technical assistance. You can see many of them there. You may have cost-related questions. And you may have questions of your own, but this possibly gets you started, and you know, these are questions to ask the developer. Okay, so that's a quick look at the NREPP website. Are there any questions about that, or comments, or people who have used the website have any comments to make or thoughts about the use of this website before we move on?
I just have one comment from somebody who said they really like it. They weren't familiar with it beforehand.
Okay, so yeah, it is useful and it's helpful. A lot of information there, but you need to do some work as well to make it work for you. And again, if you go to the NREPP homepage, you can see the easiest thing. You may know an evidence-based practice. You can just type it right in there. So that was a little bit for us about the NREPP website, introducing it to some of you maybe that weren't as familiar with it. Now we can go back to this. We had a look. Okay, so as we said, the NREPP site, it can be very, very helpful. It doesn't tell you which practice you should use for your agency, but there's a lot of information in there. Now, the Iowa PIC guidelines can be helpful as an organized way to determine whether a particular evidence-based practice will be used for you. And it's simply a set of questions. And here they are. I don't know that I want to go through each and every one of these, but we can look at some of them. They're outlined for you here, and they're available with this rather lengthy URL that you can type in. Actually, the easiest way to get to this is through the IRETA website that I found. But anyways, that's another issue, I guess. But here are the questions on the Iowa PIC criteria. And you can go through those after we send you the slides and see which ones are going to jump out at you as we just take a quick look at these. One of the questions is the practice is manualized, or they're not questions, I guess, statements, but the practice is manualized or sufficiently operationalized for staff use. Its key components are clearly laid out. Practice is well accepted by providers and clients based on clear and well-articulated theory. And there's about 13 questions or so that are here that you can review. And these questions will help to focus your mind on, okay, I really got excited about this evidence-based practice that I saw on the NREPP website. Now I really vetted it enough for my agency. These questions can help with that vetting process. And then you'll make the, decision as to whether or not you should go ahead and use this particular evidence-based practice. Now, some of these questions you can see are very suggestive. The last one, for instance, the practice can be used by staff with a wide diversity of backgrounds and training. You don't want to underestimate the importance of this. You have a staff in place. When you go out and select an evidence-based practice, you don't have the option of saying, okay, we're going to start from square one and we're going to bring in all new staff that are experts in this evidence-based practice. No, you're going to work with the staff that you have. So you want to assess your staff. You might be very excited about this evidence-based practice, but you say, our staff probably isn't going to have the expertise at this point, and maybe the training isn't really going to provide that for us, so we may need to move and protect and select another evidence-based practice, and even though this one looks attractive. But review those questions as part of the vetting process, and that will help you make, hopefully, a good determination whether or not a specific evidence-based practice is good for you. And they will be on your slide, or you can go to the URL that's listed there and pull up some good information about the Practice Improvement Collaborative that produced these criteria. Okay, let's move on and talk a little bit about Fidelity. Any questions or comments before we move on, Chris?
No.
Moving along here rather quickly.
No questions.
Okay. Okay, so those of you that are devotees of the classics will certainly recognize Cicero. And Cicero says that nothing is more noble, nothing more venerable than fidelity. And that may or may not be Cicero there, I'm not sure. But anyway, the quote is worth considering. The fidelity is very important across the board, but certainly when we're talking about adopting and implementing evidence-based practices. So let's talk a little bit about fidelity. Now, fidelity is really focused on not just one area. We think of fidelity, well, is the evidence-based practice being initiated and implemented according to the design of the evidence-based practice? But it really, we have to think about fidelity in these three areas. The first is training fidelity strategies. These ensure consistent information and skill development. So when the training takes place, we need right from the very beginning to ensure that we're providing information in a consistent manner and that we're paying attention not just to introducing people to this evidence-based practice, but actually developing their skills. So here we're not talking about awareness training, which is kind of what we're doing right now. But we're really talking about training that emphasizes skill development. So we're going to need strategies that include, really instructor and participant back and forth, master trainer manuals, teach backs. That's where the people participating in the training have an opportunity to somehow demonstrate that they really understand what's involved here. Training isn't a one-shot deal. It's going to be spread out over time. We're going to provide booster sessions after the implementation has occurred to go back and see if people are comfortable with the implementation process. We're going to provide ongoing coaching and mentoring as part of the process. So training then is seen in its broadest and really its most specific sense, that we're going to provide information, but we're also going to put a lot of emphasis on skill development and over time interventions with the people that are being charged with implementing this evidence-based practice. We're also going to pay attention to intervention delivery strategies. This is what we think of, I think, when we think of fidelity measures with regard to evidence-based practices, because we want to ensure that an evidence-based practice is delivered by staff as close to the original model as possible. That's what fidelity generally means, that if we're faithful to the model, we should experience the same effects that were caused by the original model developers when they were in the research phase. So we're looking for a cause and effect relationship here. I am doing this model, and it's going to produce these effects. And the closer we stay to the model that was developed in the research world, we should get the effects that they are saying we should get if we stay close to that model. So we want to have strategies in place that help ensure that we maintain this fidelity. And we want these could be all kinds of things. We want to measure and guide the delivery of the evidence-based practice. We might need written intervention guidelines that can be useful for helping people to stay focused on fidelity issues. We may use standardized or scripted type of protocols. There may be obviously a manual involved which can help us along the way, those kinds of things. So we're going to look at the intervention delivery strategies. Then we're going to look at intervention receipt strategies, which help to ensure that the intervention is having the intended effect. So it's not enough just to do really, really good training and skill building and make sure people have all those skills in place. It's not even enough to watch people as they're actually implementing the evidence-based practice to make sure they're staying as faithful as possible to the model that's come out of the research world. But we want to go back and say, well, is this intervention having the kind of effect that we intend it to have? And this means we have to check in with the patients by using some kind of questionnaires or focus groups, some kind of structured interviews, some way to determine what were the reactions of the patients or the clients, to this intervention. And this needs to be done, could be done in person, could be done on the phone, can be done in periodic follow-ups with patients, 3, 6, 9 months into the process. So we want to make sure we're checking to determine that the fidelity is carrying over to the people receiving the intervention. So those three things are very, very important as we consider fidelity. Okay, let's consider some other questions related to fidelity. We may need to ask, is the formal program manual being used if one is available? As you peruse the NREPP website or get in touch with other kinds of evidence-based practices out there, some of them come with a manual. One that comes to mind, for instance, is 12-step facilitation, which uses a manual. So we want to make sure that the manual is being used and not just, oh, yeah, I did read the manual, but I don't really use it. I use my own stuff when I go into a group or when I go into the session. Because then we have creep away from fidelity. We also want to know if you have developed your own written procedures and practices for implementation. So there might not be a manual, or even if there is a manual, you want the agency to develop written procedures and practices that support the implementation of this particular evidence-based practice. We also might want to know, did you provide, as we talked about earlier, staff training required by this evidence-based practice? Each evidence-based practice requires specific staff training, some of which we saw when we looked at the example on the NREPP website. And we want to make sure that training is being provided for staff. So those are important. That's an important question to ask. We also want to ask if the amount of supervision consistent with the evidence-based practice in terms of time, frequency, duration, etc. This can't be stressed too much when we're talking about fidelity. In many respects, Fidelity equals good and effective clinical supervision. And I know many agencies are stretched and stressed in regard to providing good clinical supervision. But if you're going to adopt and implement an evidence-based practice, good clinical supervision has to be in place. It's the best way to ensure fidelity. If supervisors are well trained in the evidence-based practice and understand it well and can articulate it well, they're then going to be the best mentors for the people that are actually on the ground implementing this practice on a day-to-day basis in the agency. They're the ones who will oversee the routinization of this evidence-based practice at your agency. So that's a consideration that has to be a priority for you as you move forward. You need to provide enough clinical supervision in terms of time, frequency, and duration. Agencies can struggle with this because funders often don't pay for clinical supervision time. Time spent with the supervisor in face-to-face clinical supervision is not time that can be spent in a billable service or in a fee-for-service event. But getting back to the principle that if we have in place evidence-based practices that help us to retain patients in treatment and produce successful outcomes, then clinical supervision can easily be paid for that way. The bottom line will improve. If you're providing a quality product, patients stay in treatment, and good outcomes we are able to demonstrate those, then good clinical supervision really can be paid for. Okay, are the supervision techniques utilized consistent with the requirements of an evidence-based practice? So some evidence-based practices can require one-on-one supervisory sessions. Some may really require observation, that the supervisor needs to be in the room or in some way review an audio tape or a videotape of a session. Some may just require record reviews, and we want to make sure we're using the ones that are consistent with the requirements of the evidence-based practice selected. Did the implementation vary from the model? This is very important to note whether this has happened. We'll talk in a minute about adaptations, but we want to know whether this is occurring or not. And if so, was the variation supported by a planned rationale? And again, when we talk about adaptations, we can talk about that. So spontaneous variations are not so good. Hey, I just had this great idea, and no, it's not related to the evidence-based practice, but it really seemed like fun at the time. We want to really have a planned rationale if we're going to introduce variations. And we'll see what might go into that plan in a few minutes. Okay, does your organizational culture continue to support the evidence-based practice? These three kind of go together. Does your agency have the necessary supplies to effectively continue the evidence-based practice? And does your agency have sufficient staff trained so normal attrition doesn't threaten sustainability? When we talk about the guidelines for implementing a change process, really those guidelines were meant to focus an organization in developing a culture that's going to support change and it's going to support the implementation of evidence-based practices. So hopefully that cultural change has happened and the organization is in a good place in terms of continuing to support the evidence-based practice. Obviously, you need the supplies. For instance, if you're doing motivational incentives, you know, that does require a bit of a cost. The incentives, you know, may involve clients receiving rewards, if we want to call them that, or incentives, let's stick with that word, as they comply with their treatment plan in specific ways. And so you're going to need to be able to continue to do that and to have those supplies provided on a continuous basis. And this third one is very important. You know, do you have sufficient staff trained so normal attrition doesn't threaten sustainability? Because you could put a lot of effort into skill building training with the staff as you kick off the evidence-based practice, but then those staff move on or move out of the agency and new staff come in. Well, do you have enough staff, trained staff at all times to make sure that the evidence-based practice is sustained? Do you have an ongoing training program so that when new staff come on board, you're able to say, hey, this is how we do this here at the agency. We do this particular practice, so we're going to need to train you in it as part of your new hire orientation. so that the evidence-based practice doesn't kind of trickle away because staff move on, and that's something we need to be very careful about. Okay, let's talk a little bit about adaptations. Now, successful adaptations are made in consultation with the program developer. If you recall, when we were on the NREPP website and we showed you the left-hand column there, you saw who the program developers were. It's important to consult with them and to call them and say, hey, we're considering this adaptation to the evidence-based practice. Do you have any comments about that? Do you have any pointers for us? Does this seem okay? Bring the person, the program development person into the conversation. Are the adaptations consistent with the theoretical foundations of the program? So we want to make sure that we're not straying from the foundations of the program, that we're staying consistent with the way the program is designed. Okay, we want to make sure that successful adaptations are documented and referenced when conducting and reporting evaluation data, so that we're, again, aware. We're this kind of a self-awareness thing as we go through, that the adaptations haven't just creeped in, but we're documenting them. We know they've occurred. We're referencing them when we're doing our reporting and evaluation, of the data. Again, successful adaptations, if possible, make the adaptations after the original model has been implemented with Fidelity. So the mantra is first do it right, then do it differently. Adaptations that are kind of just taken off the shelf at the beginning of the process can be a little dangerous. So it is worthwhile saying, okay, maybe this isn't an exact fit, but we want to do this evidence-based practice the way it's designed first. And then in the process of doing it that way, certain changes, tweaks may begin to present themselves, and we'll want to begin to look at incorporating those into the process as we go along. But we don't want to start necessarily with the adaptations. We want to be doing the model properly as it's been designed with Fidelity first, and then maybe adding the adaptations as we go along. Now, adaptations, can certainly be made for legitimate reasons, and we can certainly talk about some of those and consider what some of those might be. Okay, we also want to conduct an evaluation of the adaptations after they have been implemented, so that we can see whether they're being effective or not effective. Now, some of the reasons we may want to do an adaptation is that we might want to take a look at our particular population, and we may need to make some adjustments based on cultural reasons, or we may need to make some adaptations based on a particular age group that we're working with, or other kinds of things that are specific to our agency. So it's not outrageous to think that we're going to make adaptations, but we really want to do it in an organized way, and one that keeps us as close to the model as possible, and certainly in consultation with the folks who develop the model, or who are the keepers of the model at this point, if there's a model that's pretty old and the developers may have moved on for some reason. Okay, let's for a minute consider what some of the hallmarks of a watered-down program might be and how we can address some of these. We can have drift. Agency issues and agendas begin to take priority over evidence-based practices or the program's mission. And this can happen to busy agencies, to agencies under stress. You may adopt a practice in a relatively stress-free time, but the agency experiences some stress, and the evidence-based practice may just start to drift away, and that's not a good thing. If an agency decides that it has to drop a particular practice, it's better to do that in an organized, transparent way than suddenly you just notice 6 months later that we're not doing this anymore. So agency issues and agendas, we have to watch out for that kind of drift that can occur. Implementers picking and choosing from the model or the curriculum components at will, and this is where good supervision comes into play, because in the rooms or in the sessions, things can be going on, and the implementers may just be picking and choosing, having a cafeteria approach to the evidence-based practice. So it's always good to do the checking, do the booster sessions, do further skill building if necessary as part of the process. It's not simply an event when you adopt an evidence-based practice. It's an ongoing process in order to ensure fidelity. Okay, we also have program staff who can't give a clear and detailed description of the program model. This isn't good. I remember that I once worked with when I was an administrator at a treatment center with a fellow administrator. He used to say that I want to understand something clearly enough so that if somebody wakes me up at 3 o'clock in the morning, I can give an accurate description of what needs to be described at that point without thinking about it. So we want to be able to wake our staff up at 3 o'clock in the morning. I'm not suggesting that you use this as a supervisory tool, but hey, if you want to be creative, I guess you could. But we want to be able to wake them up in the morning, and they can give a clear and detailed description of the program model. If they're able to do that, it means they've absorbed what the model is. They understand it. They understand its parts. They understand its importance. They understand the benefits of using this model. And so that's an important thing to check on from time to time, to ask staff if they can really describe it. And if they can't, it means we need to do some remediation work. It doesn't mean that we shame anybody. It just means that we need to do a little remediation work. Again, since I just had this experience last night in the emergency room, one of the things we were trying to work with the nurses around was, can they describe for us the expert model? Can they tell us what the elements of it are? And their ability to do that indicates that they at least can grasp and articulate what it is. And that's an important step in determining whether they can actually deliver the model out on the floor, when the patients come into the emergency room and need to be screened and need a brief intervention or even a referral to treatment. Also, program staff who cannot, modifications, and I already said that one. Modifications not being clearly identified within the implementation process. So we don't want those modifications to creep in such that we think that they were always part of the implementation process. We want to be able to highlight them and say, okay, yeah, we made this modification, and we made it for this reason. We made it because most of the people who come to our clinic speak Spanish or are from a culture that views the world this way rather than that way. Or we've adapted it because we see a younger population, or we only work with females, and so we've adapted it so that it's appropriate for the female population. And we made maybe some additions. Sometimes adaptations that are additions to a model are better than completely changing a model. We keep the basic model intact, but maybe we're adding some notes because we're dealing with an all-female or an all-male population or a Spanish culture or whatever. Not to say you can't make other kinds of adaptations, but sometimes, those are the easiest to deal with. Okay, should you drift off track, what might happen then? Should we send out the evidence-based practice police and have you arrested? Probably not. What we should do is to consider ways to get back on track. The first thing is certainly we don't want to sweep concerns under the rug. We want to identify areas that pose challenges and lack of clarity. Staff will give us feedback as long as we're keeping them in the loop and as long as we're listening and we're not putting people down. We need to use our good motivational interviewing techniques here with staff sometimes because we want to be open and listening to the feedback that we get. And if people have concerns, I don't have time, or yeah, I'd like to do that, but I seem to run out of time, or we get distracted and we go over here instead of over there. We want to hear those concerns. We want to help people identify those early on if possible, but at any time if necessary. We want to address challenges because people will tell us things that are real. One of the things that, again, not to keep harkening back to the nursing project that we're involved in, but one of the things that's real is the emergency room situation is not like the lab, or it's not like another situation that's quieter or easier to work in. It has its own set of challenges. Well, we can't simply go in and say, well, no, you do it this way. See, here are the steps. You have to do the steps this way. We want to hear back from the people in the environment, okay, well, we want to do the steps. We want to keep the model intact, but how's it going to work here? You know, how's the process going to work? What's going to make it work? And so we've been engaging the nurses in helping us to determine what process, never mind about the content of delivering, you know, what that model is, but let's first attend to the process. How's this even going to happen? And then when we have that clearly in focus, then we can really focus in on the content and make sure that that particular practice is being done with fidelity. But we always want to hear those concerns. We don't want people to sit there quietly and think, huh, this isn't going to work, but I'm not going to speak up because I know if I do, they're going to slap me down. We want people to speak up. We want to hear concerns. We don't want to sweep them under the rug. We want to take stock of the strengths and weaknesses related to program fidelity and adaptation in an honest way. We want to see how we're doing, how we're being strong in implementation, and how we're being weak, and what we can do to remedy that. We want to make sure we document what we've done, or if we haven't been documenting up to this point, we can take that no looking back approach to start documenting what you're doing as of today. Because we want to have almost a historical, not only a historical record, but a record that's in place so that when new staff come on board, we've already, you know, kind of made those mistakes and we know where we're going from here. We also want to make the new or renewed approach to fidelity and adaptation a team effort. We don't want to lose that concept of the team. So if we're a little bit off track and we want to get back on track, let's get the team together again and say, okay, things were going pretty well there for a while, maybe not so well now. What do we need to do in order to bring us back into focus and let the team tackle that issue? We want to access support and resources from program partners and developers. We talked about contacting the developers and bringing them into the conversation. This is very important if we need to get back on track. It can also be helpful if we're able even to set up a little learning collaborative with others who are using this particular evidence-based practice. People in your region or people even outside your region. People who may be dealing with your population, that would be helpful, but even people that aren't. People that are using this practice, getting together once in a while, maybe via telephone, to exchange how it's going, what's worked for them, what's helped with with keeping on target with regard to fidelity. Don't feel that you need to be out there alone and you're just doing this and you're sinking or swimming on your own. It's better to be collaborative. Others are out there using the particular practice that you're using. Join with them in determining, you know, what best practices are as you move forward. And so don't be afraid, certainly, to do that. Okay, so that's the broad sweep here of selecting and implementing evidence-based practices. I'm going to pause for a minute. We're not completely done yet, but we're getting near the end here. And if anybody does have any comments, or particularly those of you that have already done this, if you have some encouraging words, hopefully for people that may be considering adopting an evidence-based practice, now would be a good time to let us know your story. So if you have a thought or a comment, we'll be happy to hear it. Okay, well, I guess I hope you're out there.
Yes,
some of you are still out there and with us.
I was just going to remind people that if they want to use their phone and ask questions that way, they just need to raise their hand or click on the little hand icon next to their name. We'll see that and unmute their phone.
Okay, yeah, so you don't feel like you need to type in a whole big thing. You can make a verbal comment by doing what Chris just had to say. Okay.
And I've got one already.
Okay, well, let's hear from someone.
I know this person. Okay, go ahead, Lisa.
See if we can hear you.
Lisa, it looks like you're using a computer speaker, so unless you have a really good microphone, it might be better to call.
I don't hear her.
Okay.
Yeah, we can't. It doesn't work very well with computer mics aren't strong enough generally
To pick up the voice. So for anybody who's on the phone and wants to speak
or has a real good
microphone on their computer, please just raise your hand. And, oh, here, Jim, I have, let's see. Okay, I have a question. How do you relate evidence-based treatment to a methadone treatment program?
Okay, well, that's a very good question, I think. And there are certainly evidence-based practices that are adaptable to methadone programs that, for instance, would also provide support in group therapy or individual therapy with patients in addition to their coming to the clinic to receive their methadone. There are certainly counseling techniques that are on the NREPP website, for instance, that you might want to pursue. There's even motivational incentives have sometimes been used in that setting effectively. So there are definitely practices out there that will hopefully increase client retention and client compliance with the requirements of the methadone clinic. So don't think that there aren't, because I think that methadone clinics are not just methadone clinics, they're also counseling clinics, and a lot of those techniques can certainly be used, you know, in that portion of the program. And I know a lot of methadone clinics will struggle sometimes with getting people involved in the counseling portion of the program, and there are some techniques out there that you know, can be used and can be helpful, you know, with that population as well.
Okay, I think we're going to try once more and see if we can hear Lisa here.
Lisa would be worth hearing.
Yes, Lisa. Lisa is not coming through. Okay.
All right. Well, we'll continue on. There's just one more thing I want to go over, and if Lisa is able to contact us in the meantime.
Yes. I do have one more typed question, though.
Okay.
I'm in the process of starting a state licensed halfway house for men on medicated assisted treatment. She can't call in right now, but wants to know how they can get information on agencies that have implemented an evidence-based practice on that topic.
Okay. One of the things that you can usually turn to in a situation like that is the state itself. The licensing office in your state, I'm not sure which state that the person is in, but the licensing office itself would have information about practices across the system because they do licensing visits. And I always found, even when especially when I was in the treatment world, that even though sometimes we fear when the licensing specialist comes to the treatment center to do the licensing visit, when we get over that fear, there can be a wealth of information. They know what's going on across your state. They know which agencies are doing innovative practices. In some instances, they would ask us to share what we're doing with another agency, you know, that was involved in a process similar to the one we were dealing with. So I would start with your licensing agency and give them a call and let them know what your situation is at the halfway house. And they will know of other halfway houses that are doing things related to medication-assisted treatment and be able to put you in touch with those other agencies and would start a nice kind of linkage. And those kind of linkages, I think, are very, very useful when you're talking actually to people in the field, in your situation, that are using practices that you're interested in using. I mean, that is very, very helpful, I think. But use the state as a resource in that particular instance.
Jim, I have one other person. I'm going to see if this will work. Again, it looks like they're using computer speakers, but we'll try. Sherry Hathaway.
Oops,
Sherry,
not too
can
much.
we hear you?
No. Are you hearing?
No, I guess not. Again, it looks like she's not on her phone. So, Sherry, please just type in your question. Thank you. Thanks, Jim. Go ahead.
Yeah. Okay. So, you know, this is one of the downsides of the webinar. The technology doesn't always work so smoothly, so I appreciate your patience. through this process, and I'm sorry about the glitches. And if people have questions that they want to send us an email or whatever after it's over, we'll certainly try to respond that way. Okay, I just wanted to draw your attention to a resource that's available through the Addiction Technology Transfer Center network, and that is the Change Book, which is a blueprint for technology transfer. This can be a helpful guide for you, and it's available. In fact, we'll go back to the website here, I hope, and we're going to go up here to the search the network box, and we're going to write in Change Book. And we're going to go, and here it is. Okay, and you'll see that this book is available. This is a blueprint for you with regard to making meaningful changes in your agency that will result in not only technology transfer, but the adoption of evidence-based practices as well. It'll get to those issues related to organizational change necessary, to make the to adopt that evidence-based practice that you're interested in. So this is just another resource. We've shown you the NREPP website. We talked to you about the PIC, the Iowa Practice Improvement Collaborative, as a way for you to narrow down and to vet evidence-based practices to see if they'll be useful in your agency. And now here's the Change Book, which you can either buy. I think that these are $4 a copy, or like all information on the ATTC website, you can just download it. And there's a Happy Change team right there, working diligently, I'm sure, on designing a way to implement an evidence-based practice. And then here's the table of contents, the kinds of things that you're going to see if you download the Change Book. The principles of technology transfer, a blueprint for change, and it goes through step-by-step implementation and evaluation. It's all there available for you. As I say, you can download this from the website. I think you can purchase a hard copy if you want to. But I know of agencies that have used the Change Book to very, very good effect as a way to help them through this process. So I just wanted to point out that resource to you so you would be aware of it in case you want to move ahead and make some of these changes and adopt an evidence-based practice for your agency. Oops. Okay. Here we go. All right. So that's pretty much it. I don't know that that we need to continue any further. I'm sorry that we weren't able to get the comments in because it would have been great to hear from people who are familiar with this. But I hope for those of you that are considering adopting an evidence-based practice that some of this has been helpful and that you use some of the resources that we've outlined for you here today. Thanks for your patience through this process. We appreciated having you with us this afternoon. And it's good to leave on a positive note. Here's a little quote from Charles Darwin. It's not the strongest of the species that survive, nor the most intelligent. This is good news for me, but the one most responsive to change, so that we know that that's at the heart of the theory of evolution, that adaptability, that willingness to make changes that are effective and that help move the process along. So hopefully all of us can be involved in changes that are positive and produce good results for the clients that we serve. So thanks for your time and attention, and as we move into the holidays, certainly happy holidays to everyone out there. Continue to be in that peaceful and serene mindset that I'm sure you're all in right now. Thanks very much.
Okay, Jim, I'm going to just remind people that after this webinar, probably tomorrow morning, you'll receive an email from me that will have the PowerPoints from this session. Very important, an evaluation that we ask you to complete. It just takes about 2 minutes. It's online, and this is a requirement of our grant. So it's very important that we have everybody complete that form. I'm also going to send you a certificate of attendance and then an order form if you need to get CEUs. So all that will be coming. You can check that website listed there for any upcoming webinars.
So on that point, I think we will stop the recording. And again, thank you for participating.